Hello, everyone, and welcome to today's webinar. It's all about revenue, MACRA final rule. My name is Alex Goulding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you'd prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit your questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We'll collect these and, time permitting, address them during the Q&A session at the end of today's webinar. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. Before I introduce today's speaker, I would like to note that today's webinar is the 6th webinar of iHealth Innovation's MACRA Final Rule series. Please keep an eye out for our upcoming Final Rule webinars that are specialty focused for radiology and primary care. In addition, there is an orthopedics MACRA webinar today at 2 Eastern and cardiology today at 3 Eastern. I'd now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's Chairman Emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin is formally addressed or testified before Congress, as well as the last 2 presidential administrations, on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and thank you very much to everybody joining us today. I'm going to spend about the next 58 minutes or so covering a lot of ground. And if you've ever heard me speak before, I apologize in advance. I do tend to talk fast. I'm originally from Boston, but I do try to slow it down a little bit. But we do cover a lot of content. So as Alex said, we're going to share all this information out with you. We'll have a recording that we will share with you. You can share with your peers. We'll also follow up and share all of this information, all of these slides in a PDF form over the next day or so. We will have time, hopefully, towards the end for some questions and some Q&A. And if we don't get to your question, we'll certainly look to get to it offline over the next couple of days. But again, thank you for taking an hour out of your busy schedules to cover a fairly important topic. I do spend a lot of time running around the country talking about these items, working with the administration. I've already been in engagements with the Trump administration. So I do want to touch a little bit on MACRA before we dive in. Certainly we have President-elect Trump, and there certainly could be some slight modifications, but for the most part, MACRA, MIPS, and the Quality Payment Program, we call it the QPP, is going to be in full effect. There's no dramatic changes. If you're on the health insurance reform side, there's going to be fairly significant changes coming. But if you're as your provider navigating MIPS and alternative payment models and the quality payment programs, those are all bipartisan and moving right through. These are actually a lot of Republican strategies before they're part of the Democratic bill back in 2009 and 2010. So these are moving forward. It just happened to be that Tom Price has been appointed or nominated, I should say at least, for Secretary of Health and Human Services. Tom is actually a 20-year friend of mine. I've worked with him on 2 different ventures. And the only thing he would bring to this is maybe even simplify some of the reporting requirements come 2018. He's a 20-year plus practicing care provider here in the Atlanta region. He's an orthopedic surgeon. And he will try to make this program even easier for providers. So I think this is a win for care providers and doctors and others alike. So I think that if you do see anything, it'll just be a little bit easier on the reporting side come 2018 and 2019. So I want to address that right off the gate. So you've taken the time to invest here with us today. It's very good time spent. We're going to go through a lot of best practices. And I do start off, I take a step back, and we're going to dive into MIPS and the QPP. And we're even going to dive into a lot of the specialties and the incentives for each of your specialties. But when you look over 2017 and 2018, 80% of revenue opportunities are going to come from business strategies, and optimizing your revenue cycle, and maybe even 90% of additional revenue. It's what we like to do. When we work with practices in health systems, we bring an extra 5 to 10 to 15% revenue and cash flow, because we not only work on the MIPS and the QPP and the alternative payment models that they engage and we bring them into, but also we shore up their revenue cycle. So, and their business practices and their business processes. So I'm going to talk a little bit about that before we dive into a lot of the MIPS and the MACRA stuff, because this is just important for everybody as employees of businesses or business owners. I'm a small business guy. I have been for 20 years. So I really like to help everybody run efficiently, innovatively, and effectively, so they really make the most of the money, their hard-earned money that they're earning. So real quickly, for physician practices and hospitals, it's going to be important to look. Your business can't stay operating the exact same way. Look at new strategies, new services to layer on. I'm going to give you a couple of those, but certainly if we ever talk past this, we'll give you a lot more. But look at expanding different services or service lines, devices, different types of equipment. There's a lot of strategies, but you also want to match those up to your fee schedule, so you don't just bring on a new piece of equipment, but you don't get good reimbursement for it. There's a lot of strategies there that we like to help people with and make sure they're all balanced and you don't get caught there. Also, new partnerships. When I talk about selling out to a hospital or another practice, something that I'm near and dear to my heart, my entire team's heart, and one of the reasons we've been doing business together for 20 years is because we try to keep physician practices independent. Sometimes it's right strategically to sell out, and that's perfectly fine. But if you don't want to, you don't have the pressures to, then we want to certainly give you the ability to stay independent. So look for different types of partnerships, either bring on more specialists or participate in new types of plans or care models in your community, or even expand specialties and become a larger multi-specialty group. I just met, and actually a couple of new customers out in California, they're a gastro and cardiology practice. We're able to have some economies of scale and bring those economies of scale to them by integrating them a little bit. So there's lots of unique opportunities to optimize your practice and increase revenue and your bottom line and successfully navigate these new care models. Also, we want to expand consumer access to care. We want to make sure that it's easy to do business with your organization. I'm going to talk about that here in a moment as well. But let's also explore management and risk-based contracts. So when I say that, it's not just what MIPS and the Quality Payment Program is doing, but a lot of your private carriers or commercial carriers offer different risk-based contracts. And sometimes practices might be dabbling on one or two. Hospitals usually dabble in more than that. But that's something that is near and dear. We can certainly help you with that. But it's going to become more of your strategy, certainly 2018, 2019, but also maybe in 2017. We want to look at those more quickly just because there's a lot of opportunity there and there's a lot of upside. If you handle them right and manage them right, a lot of upside. And as I already mentioned, it's near and dear to our heart to keep physician practices independent and find those financial levers to do that. But there's a big sway. There's a sway to sell. There's still a sway in the market to sell their practices. I'm dealing with one actually just this morning and actually working on a unique way to actually keep them independent potentially. But there's also a swing of practices who have sold off over the last 3-4 years that they're coming back in the market. I worked with 2 of them yesterday that they sold their practices and now they're coming back out into private practice because it wasn't the right opportunity for them. So just something, different strategies to look at. But also, the other thing to look at here is something that we call the underlying multiplier effect in shifting payment models. When we say this, there's so much tied to the future strategy of your practice around value-based care, outcomes-based payments, quality care, quality-based reporting. This is going to impact your panels that you're on with payers, impact your referral streams, impact patients and what patients are looking for in their care providers, access to the patient's information. Patients want access to information. I promise you that. Financial impact that if you're not participating in these new care models, what it means to your organization. I'm going to cover some of that later on. Again, try to dive in by specialty. But it's something that we want to address with you to understand it's beyond just what MIPS means to you. It's beyond just what Quality Payment Program means to you. There's a lot of other multipliers here for revenue that you want to look at. Again, Medicaid is moving into these types of models in different states. All commercial payers have different value-based care, risk-based contracts available. They may not have them available to you per se yet, but we want to try to pull on those. They may be available in your community. You may even be competing with other practices that have those models. So we want to look at that. And then also, like I said, in other commercial payers are all moving in this direction. So it's something we want to keep an eye on. So now, let's talk about some specific strategies. We want to optimize resources. We want to ensure that we have efficiencies and best practices. We also have economies of scale. If you want to grow your practice, how can you do that just without layering on more cost? And there's lots of ways to do it. We're going to talk about optimizing the revenue cycle. We're certainly going to dive into that in a couple of slides right before we get to the MIP stuff. But also look at new services and care delivery models, as well as specialty-specific programs that might be available to you in your community or by CMS or by other payers. But then also make it easy, as I mentioned, on the consumerism side, make it easy to conduct business with your organization. People say, well, of course, that's easy. We always do that. Well, do you? It's about aligning processes, services, and innovation to ensure that patients can easily engage your practice or your health system. So when we say that, is it easy to schedule appointments? With a lot of practices, it's actually not easy to get through. They have to leave messages. People call back in an hour or 2 or 3 or the next day. That's tough because, think about you calling into somewhere. You want to make an appointment right when you're ready to make it, when you have your schedule up. And so you want to find ways, there's easy ways to put an online scheduling or have access to different resources or shift resources so people can actually answer the phone, take those appointments, and handle those incoming calls. So make it easy to schedule appointments. I'll make it easy to actually have an appointment with your organization. There's a lot of technologies that actually can help patients find your practice, can navigate around a large, complex environment, a hospital environment per se, but also to be seen within the first 15 minutes of the patient's appointment, or certainly within the first 20. There's a direct correlation between someone who feels their quality care is decreased by the time they're waiting in the waiting room. Even if the care is not decreased, same quality or even maybe higher quality of care, but it's perceived as less if they have to wait more than 25 minutes in the waiting room. It's a perception. But perception is reality in most cases. And also, with patient satisfaction becoming 5 to 15% of future revenue streams for practices and hospitals, it's going to be very important to think about that patient flow. So just think through, your organization and how it is to conduct business. Easy to make appointments, easy to be seen when someone makes the appointment, but then also patient pay. There's a lot of great strategies out there. Again, these are all pennies on the dollar to implement, but making payments, so like I think Patient Co is a great product to make payments, make it very easy. You want to make sure you're collecting copays on the front end. It might be more uncomfortable, but getting that dollar right when that patient presents themselves and getting that copay, very important. And understanding that that patient does owe a certain copay and having that quote-unquote adjudication on the front end and understanding those and those authorizations are very, very important. It'll save you a lot of money, increase your collections, and certainly increase your ROI for what you have for employees and for technology. And a lot of these, we deploy at our practices are pennies on the dollar. ROI is in the 500 to 1,000% range. And also modernizes the practice and helps you keep pace with how healthcare is evolving. Real quickly on some of the revenue cycle best practices that we like to deploy and we try to help practices with. We want to look at documentation, mitigate issues because there are a lot of issues, which really reduces the risk and certainly of audits. So we want to look at comprehensive documentation. We want to look for under-documenting. People naturally under-document because they don't want to get audited, but then you leave so much money on the table, tens of thousands, hundreds of thousands, or even millions of dollars every single year. Lots of practices we find anywhere from $100,000 to $500,000 per provider by inaccurate coding. So it's significant ROI. You want to make sure that assessments, questionnaires, evaluations, services, tests, and screening, all that you're doing a lot of the work today, but you're not getting paid for it. I promise you, because if you're not documenting it, you're not capturing it, you're not billing for it. And also, it's not being documented. And also, when you capture it and you document for it, it all counts towards MIPS and other quality payment programs that you wanted to go for. When we walk into practices, they're doing sometimes 50 to 80% of the necessary documentation to be successful with MIPS or meaningful use, but they're actually not capturing that information inside their EHR at the point of care and integrated it into their workflow. That's very, very important. And we find all that by doing random chart audits. We recommend 10 per provider by an expert biller, monthly or bi-monthly. It makes a big difference, a lot of money on the table, saves you a lot of hassle when you try to do quality reporting, and to qualify for MIPS and these other programs. So it's a win-win-win for everybody. And also, you want to look for missing charges. And this is why an expert biller, not your standard biller who does this every single day because they don't know what they're doing wrong, but you can have experts come in there and look for missing charges. They're looking for consultations that were done, no notes are provided, wrong provider noted, downcoding, upcoding, wrong ICD-10 codes, missing modifiers. All of these, it's revenue leakage, but they also, when you do them right, they prevent rejections, they prevent denials, and they prevent audits. And it'll increase your billing by cash flow and revenue, probably by 4 to 5%, just these items, if not 10%, depending upon. And I spent 3 days in practice this week, and I found all of this. So this is all real-life examples where we're able to find tens of thousands, hundreds of thousands of dollars for a standard provider every single year. And like I said, keep the future in mind. You want to optimize your coding and have it fully integrated into your electronic health record because it'll help you qualify for PQRS. All these PQRS letters are all coming out now of providers who didn't submit their measures in 2015 are now getting cuts in 2016. And so we're trying to help clean up some of those people who are just bringing us in now to kind of clean up the mess that they have. But we're, getting that squared away, making sure everybody submits their 2016 PQRS measures so they don't get any penalties. And then moving forward, they don't have any penalties moving forward. So really showing up a lot of practices in this regard because these letters are all starting to flow. But also setting up for MIPS and any other alternative payment models or quality reporting initiatives that they want to do. And like I said, 50 to 70, 80% of what you're already doing today probably will qualify you. We just want to make sure that you're capturing all this information out there because inside your EHR or your workflow. We want to make sure you're managing credentialing, monitoring PAR and non-PAR care providers. Leverage a partner. We have one example where it's a larger health system, but we saved them $9 million a year, brought them $9 million of additional revenue by making sure their denials, making sure they're coding, and also credentialing. We play the game with the payers. The payers, in this regard, this is in New York State, they were basically pulling the physicians off the rolls, the panels, every single month, and we had to re-credential every single month, every single provider. But if that's the game we have to pay, we pay it. We'll play that because, again, $9 million additional revenue to this health system in New York. And we do this with providers all day long as well and their payers. So you got to play that game with the provider, with the payers. And again, optimize collections through eligibility verifications, prior authorizations, so much opportunity there to make sure that you're going to get paid for the service that you're about to provide. But then also, this is where copays will come in and so much revenue collection. And there's so much that can be done on the front end before the patient gets there to make sure that you're going to have a good visit and you're going to be paid optimally for that visit. And then also managing fee schedules. We look at this every 6 to 12 months to make sure you can just do some audits to look at making sure the payments that we're getting match the fee schedule that was signed with a payer. Average 30% of payments aren't matching up when we go in and do these audits. And we recommend these audits every 6 to 12 months because there's a lot of money to be found. Also, we find a lot of providers go buy new equipment, but they never match up. The sales guy will sell them this great equipment, talk about all this great new revenue they can create, but no one went back and matched it to their fee schedules to make sure they actually can get paid for that service or get paid at what that salesperson is telling them they're going to get paid for or reimbursed for. So we like to do that kind of service for practices as well because, hey, adding new equipment can be a great service line, more revenue, but let's make sure that your current fee schedule has it or your future fee schedules have it because we want to make sure you're paid for it. So going through, understanding, managing your cost structure, you want to look at transparency and make sure you can uncover costs, and whatever we do, we want to track that because we really need to have full transparency of costs for each visit and for the operation, for the health system soon. Because to be able to assume risk and take on risk, you have to understand what services cost, what these different care models cost you, so you can go at risk. Streamlining operations, increasing throughput. We want to see more patients, see the right patients. We want to attract the right patients to a practice so you can get this increased throughput without layering on a lot more costs. Costs have increased 50% over the past 10 years, but you haven't had a 50% increase in your reimbursement or your payments. So must mitigate the cost of operation. We've got to look at staffing models. We've got to understand, can we do a co-source on the revenue side to alleviate and focus staff on new wellness, care coordination, pop health activities, which can bring you even more money. or companies like mine can help you there as well. But there's a lot of staff that you already have that we might be able to optimize and streamline so they can be on revenue-producing opportunities, not on tasks that aren't generating revenue and cash flow for your practice. So yeah, you want to automate and co-source options to improve your economies of scale, to take on new business models, to engage risk-based contracts, take on NIPS successfully. There's lots of opportunity that will not increase your costs, can actually increase revenue. Like I said, 5 to 10 to 15% a year and increase cash flow, but you got to look at a lot of different strategies internally as well as externally. So, and before I move over to the MIPS stuff, there's a lot of key performance indicators that can be set up. A lot of you probably have already invested in great health IT and great technology platforms. And if you have a top 10 system out there, you can easily do this. So we can set up KPIs so you can see how your revenue is doing, and then all the KPIs on the clinical side to see how you're doing and these different care models that you want to engage, such as MIPS or the QPP or any APM or even PQRS or meaningful use and so forth. But some also set up KPIs. One example that we like to put out there is to look at your denials. Only 60% of practices go and appeal denials. That's amazing because there's so much revenue. There's millions of dollars that are being left on the table by not appealing every single denial. So we say be tenacious on your appeals. You should be appealing 100% of your denials and going after that money. And then also look at the denial, the root causes, and that's something that with our analytics, we go in there because we don't want to just keep appealing the same denial if we can fix the root cause of that denial and not have that denial anymore. That'll bring on consistent cash flow to you with less work in the background. So certainly appeal 100% of your denials and then do the analytics to look at where are all these denials coming from, and let's go to the root of those and eliminate them so they're no longer rejected or denied. And then also, like I said, you want to look at underpayment reviews, payer analysis every 6 months. I promise you they're out there. About 30% of payments that we've looked at and reimbursements are not paid accurately per the managed fee schedule. So you also, I already mentioned this before, but patient wait times. You want to make sure that you're seeing patients in the first 15, 20 minutes of their appointment. If not, how can you optimize to create more efficiency in your practice or something with your care model? But you just don't want patients waiting more than 25, 30 minutes. A lot of bad things kind of roll downstream from there. It happens once in a while. If it's consistently occurring, you want to fix that. That will not be good. That'll be a revenue hit on you starting very, very soon if it's not already. You want to manage cancellation, no-shows, a lot of good strategies out there that are very inexpensive. Get coding turnaround time. You certainly want coding in 24 to 48 hours. You want to get those bills out. And then also, in closing, understand the true cost of a claim. That's where all this transparency, understanding your costs. Because if we know that a certain visit is $135 and a payer is willing to pay you $180 for it, well, that delta is that's your bottom line. You can actually, that's straight to the bottom line. That's a lot of extra revenue. So, but if it costs you $210, but a payer's only going to pay you $180, you can't take that risk-based contract. You can't take that capitation. So we want to look at that, and there's lots of strategies that we can deploy to help you there, but it's just a best practice on your own. You want to start to do that. So now moving into MIPS and the QPP. And again, the reason why I spend so much time in the revenue cycle is that is where 80%, if not 90% of revenue in 2017 and 2018 will come from for your practice of additional revenue. It's not going to come from these programs. It's shoring up your revenue cycle and all the hard work that you're doing today. But diving into MIPS and MACRA and the APMs, we know the final rule was released on October 14th. It's well in effect. MACRA is going into effect January 1st. Nothing is changing that. So it all starts, you don't want to wait. You want to make sure you get your dashboard set up. You want to make sure you get your workflows ready for MIPS and the quality payment program. But the good news is, if you're taking the time to join us today, you're going to be very well set up to certainly stave off any cuts the 4% cut that could be coming for 2017, because option one, as you see on your screen right now, allows providers to report on one quality measure or one improvement activity or either 4 or 5 advancing care information measures to avoid a negative payment adjustment. So you only have to do those items over a 90-day period. So just one quality measure over 90 days or one improvement activity over 90 days or 4 to 5 ACI measures, which is advancing care information. I'm going to dive into all this more here in a moment, but do one of these items over a 90-day period, and you can avoid the 4% cut. So that's the baseline. That's very easy. Everybody should be able to very easily avoid a 4% cut. Option 2 allows providers to submit a mixture of measures and activities for a minimum of 90 days. They might do, you can do 90 days, you can do 91, you can do 110, 180, 270, or more, a mixture of measures and activities, and you might be able to get 1, 2, or 3% increase. So that's a great opportunity. So option 2, we're working with most people for option 2 and option 3 because we want to go optimize your opportunity. MIPS is not a hard program. It's fully integrated into a lot of your workflows today. Certainly if you've done meaningful use, if you've done PQRS, if you've done any quality-based reporting with any payer, if you're part of any type of ACO today, CPC Plus, anything like that will make you, successful under MIPS and or the quality payment program. And so there's no reason, all these great programs out there that you've been working hard within, MIPS is meant to integrate with, and eventually it'll be your only program that you have to report into. That'd be very helpful. And as I mentioned, I think Secretary Price will only make it easier for you as he comes in and changes some of the rules or modifies some of the rules or make new rules for 2018 and 2019. So I think you're all in great shape. Option 3 is where you want to start in January and report for the full 365 days, and you can earn up to 3 or 4%. Because there's lots of different measures and activities, but also you can go for bonus reporting, and so you try to get your full 4%. We don't want to say guarantee 4%, but if you work with iHealth, we actually guaranteed you will not get the cut. We guarantee you will not get a 4% cut if we actually partner with you. But no one's guaranteeing a 4% increase. But we want to work with everybody to get 2, 3, or 4% increases starting in 2017. So again, a great opportunity. I think the program was very, I don't use the term watered down, but it was the reporting measures were significantly lowered in the amount of options were increased, and the measures and activities were all reduced, so you can really try to get your full 2, 3, or 4% increase. I think it's great. And then option 4 is the Medicaid ACO track, and that's going to be if you're CPC Plus or a shared savings track 2 or track 3, and then there's also an oncology track. One of those would all qualify for option 4. I don't know if there's any of those on the line, but anyhow, a great opportunity there. So that's the highlight. So now going over some of the numbers that we're talking about. If you participate in the MIPS program, which I think everybody on the line is focused on that, and most of our customers are focused, most of the care providers in America are going to be going down the MIPS, the Merit-Based Incentive Payment System or Service track. So that's a 4%. You can get up to a 4% increase starting in 2017 if you start in 2017. But also if you just totally ignore the program, you'll get a 4% cut. And it's not even a leverage cut, it's a 4% cut. But if you participate in the program, you can get a 1, 2, 3, or 4% increase. Again, hopefully everybody will actually participate in the program. But in year 2 for 2018, it's if you ignore the program, it's an additional 5% cut, so that'd be a 9% cumulative cut, or up to a 9% cumulative increase. So again, a lot of money out there. So you get a 5% increase for year 2, up to 5%. Year 3 is either another 7% cut or up to another 7% increase. So you're talking about 16% increase there over 3 years from where you are today. And then add minus 9% or plus another 9% for year 4. So again, a lot of opportunity for most of you or everybody on the line here. I'm not going to go to other programs because I don't think there's anybody on here, but the advanced APM, that's a 5%, but again, you have to be in a Medicare Shared Savings Track 2 or 3 or a CPC Plus program. Again, I don't think there's any of that on the phone. But as a reminder, when MACRA went into effect, everybody got a 0.5% increase starting in 2016, starting this year. So everybody saw a little bit of a fee schedule increase, and that will also stay on through 2019. So here are the MIPS performance categories. There are 3 for 2017, and there are 4 starting in 2018, but 3. So starting off with the first one, quality. That will replace PQRS, and that accounts for 60% of your total score. You also have advancing care information. And I'm going to dive into all of these individually here in a moment, but the ACI will replace meaningful use, and that will account for 25% of your total score. And then improvement activities, there's either 2 or 4 of those, and that will be, and it's a new category, and that will account for 15% of your total performance score. But again, for 2017, you only need to do 1 of these to be successful. So 1 quality measure, 1 improvement activity, or through your EHR, you can report on the advancing care information, either 4 or 5 measures, and I'll go into that more specifically in a moment. And again, all of these slides will be shared with you at the end of this presentation over the next day or so, and this recording will be shared with you as well. So no diving into these measures specifically. So for the quality for 2017, quality is 60%, and you have to get full credit, you can report up to 6 quality measures, and only 1 being an outcomes measures, and I'll dive into that here in a moment. And again, we do have over the next several weeks, including today, we have additional specialty-specific webinars where we'll dive in 30-minute high-impact webinars that will dive into these specifically so everybody can see what it means to them. We have orthopedics, cardiology, radiology, and primary care. The 2 today are cardiology and orthopedics. But then coming up, we also have a lot of those already recorded on our website. And we'll be doing more specialties. We work within 44 specialties today, so we cover all the major ones. So we picked some of the big ones out to call out for these webinars. But diving into now advancing care information, you have to you have to use a certified EHR for this. So if you have a 2014 certified EHR, you have to report 4 measures, and you report that directly from your certified EHR. But if you have a 2015, which would have the MIPS certification as part of it, you'd report 5 measures. That's option 1. So option 1 would be the 2015 MIPS certified EHR, and that's through meaningful use. That would be a 2015 certified EHR. That would be option 1. You report 5 measures, and that's for the advancing care information category. But if you don't, you have a 2014 certified EHR, then you would report option 2, which is 4 required measures. And you have 11 to choose from, but you'd report on 4 of those. And again, these are all depending upon your workflow. What's great, I'm going to cover this again in a moment, but all of these categories for quality, you have up to 6. You only need to report 1 for 2017 to save up a 4% cut, but you can report up to 6 to get your full credit for the quality category, and you're going to have lots to choose from. There's hundreds to choose from. So we look for quality measures that match your workflow and your specialty, and look for best practices there. So for example, if you're in family practice, I think there's over 50, I think there's 55 quality measures to choose from for family practice. You only need to report on 6 for full quality, for full credit, and just 1 to stay off your cuts or any cuts for 2017. So again, there's lots of ways to do this to be successful. It's not all or nothing. And again, you only need to do 1 of these categories to save off a 4% cut. So I know a lot of people saying, well, hey, I don't want to do too much. I just want to save off this cut. Well, that's very simple. Do 1 of these items, and you'll save off a cut. We're trying to get people to do more, do a little bit more, maybe get a 1, 2, or 3% increase, maybe even a 4% increase for 2017. Lots of options to do that, and a lot of flexibility that CMS has offered to do that. So now moving right down, when you look at improvement activities, which is the IA on the right side of your screen, the far right, the 3rd category, that's 15% of your category in your score. And there's 4 activities that you have to choose from. You have 93 to actually overall to choose from, but you have to pick either 2 high-weighted ones or 4 medium-weighted ones, and you get full credit. And if you don't want full credit, you just want 1 credit to save off that 4% cut, that's very simple. You have 93 to choose from. Look for ones that fit your workflow, fit your specialty, and you should be good to go. But again, and I'm going to walk through this here in a moment and show you all of these activities, but you only need to do 2 high-weighted ones or 4 medium-weighted ones, and you get full credit. And then you're well on your way to getting a 1, 2, or 3%, or even a 4% increase. So again, 93 to choose from. So what I point out there is there's lots of flexibility that CMS has offered to move forward. And again, I'm going to dive into that here in a moment. I'd like to touch on rural health clinics and federally qualified health centers and how it relates to MIPS, because we have a lot of those customers as our customer base today, and also there's a lot out there, and they're actually growing, certainly in lots of parts of the country. So it's important to know that most RHCs and FQHCs can voluntarily participate, but are not required to in MIPS. And I'll tell you why here in a moment. So most don't need to participate if they don't want to. It's good to voluntarily participate because they probably will need to in the coming years, probably in 2018 and 2019 is what we're guessing. But right now, if you are an RHC or an FQHC, you do not need to. However, what's very important, and you also will not get the cut. You will not get that 4% pending cut. But if you're on RHC and FQHC that bill traditional Medicare Part B versus the all-inclusive rate, you do have to participate. If you have over $30,000 in Medicare Part B, non-participation could mean a penalty. So again, if you're standard, if you're doing the all-inclusive rate with RHCs and FQHCs, then you are exempt, at least in 2017. I mean, you will not get a 4% cut. But if you do bill traditional Medicare Part B under or as an RHC and FQHC, and you have over $30,000 in Medicare Part B, then you do have to participate because you would get the cut. So it's a good thing to point out. And again, all these slides will be available to you at a later time. So kind of covering what we just covered before we dive into some of these specific items and all those activities and all those different measures. This program was significantly, the hurdle was significantly reduced. So it's pick your pace. It's highly flexible. You choose what objectives and measures best fit your practice, best fit your specialty, and best fit your workflow. And as I said a couple times, it's not all or nothing. You can participate in just report one quality measure over 90 days or one improvement activity or those ACI measures, just one of those items, and you can stave off a 4% cut. But if you want to actually go for 1, 2, 3, or 4% increase, then you do more of those different measures and activities, and you'll be good to go. So I like to point out that meaningful use is all or nothing. So, but this program was not built like that. This program has a lot of flexibility. It's based on your specialty. It's based on your workflow, and certainly on your practice. So I like to point that out. And there's opportunities for partial credit. There's opportunities for bonuses, and I expect even more flexibility to come. A couple months ago, or about 5 weeks ago, I published a 4-point plan on MACRA MIPS success. So I would point you to it. There's actually a link. Again, when we share these slides out there, you can go look at it. Becker's Hospital Review and a couple other publications picked this up. But I went through the 4 tenets of how you can optimize your practice today and how you can successfully navigate these models and new care models tomorrow. So I walk around financial success, clinical success, technology, and staff success. Some of that I've covered today, but I go much more in depth in this piece that I wrote about 5 weeks ago and published. So I do recommend taking a moment to download. And again, you can share this with any of this with your peers, anybody else in the industry. So now walking into the quality payment program, and what this means by specialty is my next part. So I'm not going to be able to spend a lot of time on each of these specialties because, again, we have specialty-specific webinars set up. And, again, all these slides that we shared with you, and we can always do one-on-one calls too. But I'm going to fly through these next parts, but I do want you to see some of these numbers because they're big numbers. And not only do you want to stave off cuts, you want to go after some of these payments and this additional incentive dollars. So for orthopedics, it's about $35,000 for the average practice. And then that would increase to $43,000 for year 2, $61,000 year 3, and $78,000 year 4. So, and then you start adding this all on cumulatively. Look at you're talking about $216,000 if you avoid the program. If you're an orthopedic surgeon or an orthopedist or an orthopedic practice, you get a $217,000 cut by year 4, or you can actually work towards a $216,000 increase if you optimize and maximize your opportunity here with MIPS. So, and again, I'm going to do this for lots of specialties here coming up, but I want to let you know there's a lot of money on the table here. So again, you don't want to avoid the program, and you do want to kind of get the right partner to help you set up these dashboards and set up this glide path because it far pays for itself. But also, so here's an example on your screen for orthopedics. I'm going to go through about 8 specialties now, but there's 21 different measures for you to pick for orthopedics. Now, again, it's on quality. You can report just one, but you have 21 to choose from. And if you want max credit for the quality measure and for the quality piece of this reporting program, you have 21 to choose from. You only need to choose 6. So you want to look for the ones that you've done either part of meaningful use or PQRS or any type of other quality-based reporting that you've done in the past. Certainly with PQRS is very valuable to this. So there's 21 to choose from if you're an orthopedic practice. You want to look for the ones that have match your specialty, match your workflow. Again, very simple to choose from, a lot of flexibility and offering there. Now, for ENT practices, for the average ENT, for a 5-doc ENT practice, about $20,000 your first year, another $25,000 year 2, year 3 about $35,000 additional, year 4 about $45,000. So again, a lot of money that you'd get cut if you don't participate, but if you do, those are the increases that you could get. So cumulatively, over 5 years, looking at about $125,000 cut if you don't participate in MIPS, but up to a $125,000 increase in payments if in reimbursement if you participate in MIPS. So again, some great money. Now for ENTs, on the quality measure side, there are 18 measures to choose from. So again, you just need to do one in 2017 to stave off a cut, that 4% cut, but you report up to 6 and get the full credit for the framework for quality, and you have 18 to choose from. Again, that just shows the flexibility. So that you want to look for the ones, and this is what we bring in, or companies like ours, best practices. We'll come in there and show you what measures best align with your specialty, with your workflow that you're going to look for in a partner if someone's going to help you with these programs. But again, there's 18 to choose from for the average ENT. Urology, for an average four-doc urology practice, about $30,000 year 1. You'll either get that cut or up to that incentive. $38,000 year 2, $53,000 year 3, and $68,000 year 4. Cumulatively, that's about $190,000 that would be cut if you don't participate, and up to $190,000 by year 4 if you do participate. So again, a great incentive. And for urologists, there's 12 to choose from. Again, just got to do one if you want to stave off that 4% cut. And you have 12 to choose from, or report up to 6 and get your full opportunity under the quality components, the quality measures stack, and you can get your full credit under urology for this. So, and again, you have 12 to choose from. You want to look for the ones that best fit your workflow, your specialty, and so forth. Now, gastro. For your average 4-doc gastro group, about $18,000 year 1, $23,000 year 2, $32,000 year 3, and $41,000 year 4. Cumulatively, that's about $114,000 cut that you would get for not participating in over 4 years, and then about $114,000 increase if you maximize the program for you over 4 years. Now, gastro docs and gastro practices have 16 measures to choose from for the quality category. And again, only one you got to pick to stave off that 4% cut in 2017. You'll report all 6 for the quality component, and you would get your full credit. And again, you have 16 to choose from. So you want to pick the 6 or the 1 or 2 or 3 that best match your workflow and your practice and how you practice medicine. Now, internal medicine. For the average 5-doc internal medicine group, about $19,000 or so the first year, $23,000 year 2, $33,000 year 4, and $42,000 year 4. And cumulatively, that means $117,000 over 4 years of a cut that you would receive by not participating in MIPS, or up to $170,000 increase, additional revenue, if you did participate. And internal medicine's practices have 37 measures to choose from in the quality component, in the quality program. And again, only one to stave off that 1% cut, just one measure to stave off that 4% cut in 2017. But again, 37 to choose from. You report up to 6, and again, you find that the 6 that best fit your workflow and how you practice medicine. Again, a lot of flexibility. 37 to choose from, and you only need to pick 1, 2, 3, or 4, or 6, however many, and how much money you want to go for. On the family practice side, about $10,000 for the average 4-doc family practice group. First year, about $12,000 year 2, $17,000 year 3, and $21,000 year 4. Cumulatively, about $60,000 over 4 years. If you choose not to participate in the program, that's what you'd be cut. Also, up to $60,000 increase if you were to participate by year 4. And as I mentioned before, family practice has 55 measures to choose from. Again, you only need to pick one to stave off your 4% cut for 2017, or report up to 6 to get your full credit for the quality measure component of the program. But again, 55 overall to choose from. So you want to go pick the 1, 2, 3, or 4, or 6 that best match your workflow and your specialty. And hopefully you guys all hear, there's a cadence here. This is all this, so it doesn't matter what specialty you have. There's measures in there for every single specialty and your workflow. That's why this program is not difficult to manage, certainly if you get the right partner to help you navigate you through it. On the family practice side, as we just gone through, for a larger practice though, because we have different size specialties, there are 6 doctors. For a 6-doc group, about $14,000 year 1, $18,000 year 2, $25,000 year 3, and $32,000 year 4, about $90,000 cumulatively. So again, a great opportunity for family practice, as we mentioned. That's a 6-doctor group. So now, improvement activities. As I mentioned before, you have 93 total to choose from. And if you want to go, you have to report just one improvement activity to stave off your 4% cut. But, and like I said, just a reminder, you have to do only one of these items. So report one quality measure for your specialty, or one improvement activity for your specialty, or up to 4 or 5 advancing care informations. One of those items stave off your 4%. That's how easy it is to avoid a cut in 2017 under MIPS. But if you want to actually do a couple of these, then you can start increasing your money. Certainly if you want to go for 90 days or 100 or 100, 180, 270, 300, whatever you want, up to 365, whatever you want, you can actually go for a great amount of money here. But there's 93 total to choose from. You can do 2 high-weighted ones or 4 medium-weighted ones, and that will get you your full credit for this category, for improvement activity category. So again, not difficult to do, certainly for 90, 100 days or 180 days or whatever, certainly if you get the right partner. So right here on your screen is half, and between those 2 screens that I showed you, those are all 93. And again, we're sharing all this content out with you. We only have an hour together today, so I can't go through every single item in detail. But again, this is what a partner does for you, but also we'll be sharing this out with you at the slide deck here in the next day or so. And those H's mean those are the high-weighted ones, if you see it next to it. Again, 93 to choose from. You only need to do one to stave off your 4% cut for 2017. Here are the ACI measures. We can't go through all of these, but here are your advancing care information. Those are the ones, if you report them through your EHR, your certified EHR, either for 2014, you have to do 4 of these, or through your 2015 version, which are MIPS certified version, you would do 5 of these. But again, those are all done through your EHR. And if you do 4 or 5, depending upon your EHR certification, you stave off your 4% cut. And you also get your full credit for 2017 for MIPS. So a great opportunity there. Now, also near and dear to my heart is not just what the federal government is doing, but also across the country, there are dozens and dozens and dozens of state-based incentive programs that bring you a lot of extra money. And so that's something that we like to do. We have a program, it's called the WRAP program, which is called Wellness and Revenue Assistance Program, where we work with practices to go find those programs locally. We not only set them up for MIPS and PQRS and meaningful use and other programs for the national level, but we also look locally and regionally to see other different programs to get maybe $100 per patient or $50 per month per patient, or big block payments from payers. There's lots of programs that can bring you a lot of money for quality reporting or outcomes-based payments. So we want to find those locally, because this is going to pick up dramatically starting in 2017. So it's not just what the federal government is doing, Medicare or even Medicaid in your state. It's a lot of other local programs by private payers and or by states. So there's a couple of examples: a New York example on PCMH, a Georgia example on PCMH, oncology example here in Georgia as well. Again, these are just examples. We have hundreds of these across the country. Kentucky, there's an enhanced personal health care program. There's a CPCI initiative there as well. In Florida, Blue Cross Blue Shield has a value-based care program. Again, Blue Cross Blue Shield has dozens of these across the country. So your blue certainly around PCMH is pretty significant. So, and a lot of money available to you today if you move down the PCMH path. But again, lots of programs by lots of payers that we recommend. So kind of close it out here, leave a few minutes for questions. What will it take to succeed financially? You've worked so hard, and everybody in the practice and or the hospital works so hard to provide the best and the highest level of care. We want to make sure you get paid for everything you're doing, making sure that your coding and documentation is all accurate and you're chasing down those denials. So look at those components. to optimize your efficiency, both from the financial health side as well as your clinical health side. So again, optimize coding, make sure you have comprehensive coding. You want to make sure that you're claiming and chasing down and fixing those claims before they go out the door. Denials, you want to get root cause reviews and mitigate any issues, and you want to chase down 100% of your denials. 100% of your denials should be appealed, not only 50 or 60% like most practices. Eligibility verification, make sure you're getting pre-authorization. That's something that we like to set up for practices because that, you want to make sure you're getting paid. You're doing pre-auths, certainly as in some of those key specialties. We want to look at payer contracts, variance rates. Make sure you're getting paid to what your contract says. And we will do a lot of this through heavy analysis every quarterly, sometimes monthly, quarterly, semi-annually, whatever it takes. And set up these KPIs through dashboards. So all this is done electronically and through the use of technology, not through manual processes. Sometimes we do have to do this through manual processes, but it's great when we can do it through a lot of dashboards that we just set up within your EHRs that you've already invested in. So on the clinical side, population health and care coordination are going to be part of all care models and new payment models moving forward. So we want to make sure that we're integrating data from clinical and financial sources. We want to make sure that we're customizing your EHR to capture this information, that it's all being reported on dashboards. I'm sure you guys have PQRS dashboards, meaningful use dashboards. We want to set up MIPS dashboards and any other programs that we want to capture these key measures and key factors in. We can do all that using technology. And that way you can just look back and see how you're doing. And then people like us can kind of look in and say, hey, you missed this measure. You want to step this up so you can get this max payment. There's lots of opportunity here if you monitor it, capture it, and track it and report on it. And again, I went through a lot of best practices today, but we want to implement best practices to optimize your opportunity. There's a lot of things that we can do on the revenue side. There's lots of things we can do on the clinical and the reporting side to make sure that you get your max incentive payments out there. And again, it's not just what CMS is doing, it's what the private payers are doing as well. Great opportunity to increase revenue, 5, 10, 15, 20%, and increase cash flow as well. And then look at care coordination across your entire continuum, because it's going to optimize your outcomes, which means you're going to get more money. So PCMH and these new care models, they're not just to go chase down money, but it does really improve health of the patient and hopefully the wealth of the practice. And then something near and dear to my heart as well is patient engagement, patient education, patient empowerment. Patients sometimes, and most times, are the cheapest resource because they actually know what medications they're on. They can input data that they get from other providers. You can vet it and approve it before it's part of their permanent medical record, but make them upload it into the portal. Make them, or first, hopefully you roll out a portal to engage your patients, and if you don't, that's something that you're looking into because you don't want to be fielding those phone calls when you can have all that information just automatically loaded for the patient. They can go in there, they can do automatic refills, they can exchange information and seek advice from your practice. And develop a stronger bond with your practice through those types of modalities so they don't go out to other providers. Make it easy, again, to do business, not only to call or reach your practice, but also contact through electronic means. Secure messaging. A lot of these portals all have that. And again, refill. You shouldn't be doing refill requests on the phone, at least when you can help it. There's certainly other patients and elderly patients don't want to use computers, can't use computers, completely understand. But there's also a lot of your segment that does. They use their phones for everything else in their life except for assisting with their health care. And it's all secure, HIPAA compliant. So again, I want to make sure you guys are, you understand a lot of these best practices. Because I personally believe that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. And the reason I believe this, and I know it, I'm living and breathe this every single day. I'm with practices and hospitals every single day, and I see the additional revenue to the bottom line. But also, there's more money being flooded into healthcare than ever before, and it can go into your pockets. I promise you that. And that's something that we believe in, we implement every single day, and we love to work with practices and hospitals on that. In closing, some resources. Again, we'll be sharing all these slides out with everybody. But you can see a lot of these measures. We have a lot of this posted on our website. We'll gladly help you personally. But the qpp.cms.gov website, you can look for your specialty and pull all this information down on your own. We also have our website hosts a lot of webinars. We host a lot of best practice and expert content on the iHealthInnovations.com website. Also, CMS is a great website called innovation.cms.gov that you can see what value-based and alternative-based models are in your community, right in your backyard. So that's available to you. And then also something I want to make sure everybody understands, there's a Medicare.gov/physician compare website. I call it, it's just Medicare Physician Compare. That website talks about most care providers in the country, and you want to see what Medicare knows about you because they're becoming more transparent. They're just publishing their PQRS success. They're publishing meaningful use success. They used to publish e-prescribing. They're going to be publishing MIPS in these quality payment program, all the success that physicians and care providers are having out there. So you want to go out there and see what CMS is publishing about your practice, and this is only going to involve, they're going to be publishing all these MIPS scores out there because they want to have full transparency and affect consumerism. So I just want to make sure everybody's aware of that website. It's been out there for about 2 years now. So with that, Alex, I can turn it over to you for some questions. I think we've got a few minutes. And again, I apologize to everybody for talking so fast. I try to cover a lot of ground in a short amount of time, but hopefully everybody appreciates the good content and expert content here. Thank you, Alex.
Thank you, Justin. We are quickly approaching the top of the hour, so let's go ahead and dive into our first question. If my practice decides to move forward with the partial reporting option, when is the latest we can start?
Well, technically, the latest you can start is October 2nd, and that's for the partial reporting option. But I don't recommend. I mean, we certainly understand using maybe the first quarter, January, February, March, to kind of get your strategies under your feet for MIPS. We're starting MIPS right now with a lot of our customers. That's why I just came back from a trip to the West Coast, setting up MIPS for those practices and doing that across the country. But you want to start at least understanding or setting a lot of that up in January, February, March. But the latest that you can begin and share would be October 2nd for partial reporting.
Perfect. Next question. I've heard there are additional flexibilities under ACI for clinicians that weren't previously eligible for meaningful use. Is that true?
Yes. Clinicians that were not previously eligible for meaningful use can optionally participate in ACI for 2017. By default, if you weren't previously eligible for meaningful use, your ACI score will automatically be zeroed out by CMS unless you choose to participate and submit ACI measures. So I hope that helps a little bit. I know there's going to be some providers that certainly fall into that category. But yes, you can do that.
All right. We are a 7-doc group. I thought I heard you say we don't have to report as many improvement activities as larger practices. Can you clarify?
Yeah, correct. Groups with 15 or fewer participants are only required to report 1 high-weighted or 2 medium-weighted activities to receive points under the improvement activity performance category. So yeah, correct. If you're a 7-doc group, and you got groups less than 15 participants are only required to report 1 high-weighted measure or 2 medium-weighted activities, improvement activities in that performance category. Great question.
Right. So out of respect for everyone's time, we'll just ask one more question. We have 60 clinics under one community health system. All of our community-based health centers are in a PCMH. Even though they belong to the same group, some of our specialty clinics are not in the PCMH. If we report as a group for MIPS, would the whole group be considered a PCMH for MIPS reporting?
Actually, why don't you help me with that one? That's a great question. Why don't you tackle that one? You handle that one, Alex?
Sure. My understanding is that all of the members that are reporting under one group would need to be participating in the respective alternative payment model, PCMH, ACO, whatever it is. It would need to be consistent across the group in order for it to count towards MIPS reporting. That is something that is a really good question and probably merits following up with CMS to confirm. But my understanding is that no, it would not count for all of the members if they are not all in a PCMH.
Yeah.
All right. Well, thank you, Justin.
Yeah. No, thank you, Alex. Actually, I dealt with that a little bit this morning too on a conference call. So thank you for helping guide that too, Alex. Great work.
Sure. So thank you, Justin, and a special thank you to everyone for taking the time to attend today's webinar. It's all about revenue, MACRA final rule. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you'd complete that and provide your feedback. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours, and we'll also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of Health Innovations and our presenters, thank you for joining us today and have a great rest of your day.